Welcome, welcome everyone, and happy Thursday Night Live. Look who is here with us today. What a honor and a blessing to have you on the Aries Circle stage. I have
Thank you.
followed you for so many years, and I cannot even believe you in front of me right now. So let's see, everybody. Today's topic is early mouth maturation. What to expect in utero at birth and in early mouth development. Introducing Diane Bahr, a highly respected speech-language pathologist, infant massage instructor, and international educator with over 40 years of experience working with children and adults with feeding, motor speech, and oral function challenges. A true visionary in her field, she is also a published author, university instructor, and founder of Ages and Stages. Diane's work has empowered countless families and professionals through her expertise, compassionate approach, and lifelong commitment to advancing best practices in oromotor and feeding development. Yay! You are
Hey,
very
thank
circle.
you. I'm honored.
Thank you so much. I know I already have so many questions, and you guys, if you're listening to this live, please put your questions in the comments, and I will ask them at the end. You're welcome to
Yeah.
share your screen if you would like.
Okay, so let's see. I go to share.
Yes, if you have any audio, a little screen is going to show up for you to share the audio on that first share screen. It's on the right
Yeah.
side.
Hmm.
If you don't have to worry about it.
I do. Share
Okay.
sound. I got it.
Yeah, this,
Okay,
yes, yes.
there we go.
Ta-da! All right, I'm going to turn my camera off and let you talk. I'll come back at the end.
Okay,
Thank you, thank you.
and I'll move myself to the center so I can see everybody instead of looking over. All right. So, hello everybody. I really appreciate Airway Circle inviting me to present, and I love the work that you are doing, honestly. So, today we're going to talk about early oral maturation and what to expect in utero, at birth, and in early mouth development. And look at that cutie that we have there in our first photo. And I'll be showing you some other photos. And I also have some tools here that I can share with you as we go along. So you already know this because Renata said it. And here are my books because they need to be in the disclosure. So let's see. Um, so feed your baby and toddler right, early eating and drinking skills, um, encourage the best development. Sorry, I've got a little bit of postnasal drip here. But
Yeah.
anyway,
Okay.
that's 2018. And then my daughter and my daughter is also a speech language pathologist. You're going to see two of her children in here. And we are developing a very, very large course. We've been developing it for 25 years, and it will be coming out through Northern Speech Services, and there's a program to go along with it. So that will be a new publication. The other book, Nobody Ever Told Me or My Mother That, is still probably the best book. I looked it up on Amazon. You can get it like $16. Um, if you're looking for an overall book. And then the original textbook that I wrote when I taught at Loyola University is Oral Motor Assessment and Treatment, Ages and Stages. And I did that because I was teaching, I taught 11 years at Loyola in Maryland, and we didn't have a textbook. You know, we were using Jerry Logan's book, which was great. We were using Suzanne Morris and Marcia Dunn Klein's pre-feeding skills book. That was great. Um, but we really needed one to pull it all together. And that book actually stayed in, it continued to be published for like over 20 years. So, and you'll still find it online. It's a blue book. Anyway, so I am the co-owner of Ages Stages LLC, And I've also taught for groups which you probably know, Talk Tools, the Breathe Institute, Speech Therapy PD, and Northern Speech Services. Oops. I belong to ASHA, IAOM, and IAIM, which is the International Association of Infant Massage. And I have a background in body work as well. So, these are my ideas and opinions. They're meant for educational purposes, and they're not meant to diagnose or treat any disorder. So you can read that. And then here's the description of what we're going to do. I'm hoping that this presentation will offer you informational oral development for the ultimate functions of feeding, eating, drinking, and speaking. The course we're doing for Northern is a motor speech course, actually. But this course focuses on maturation of the oral structures and functions in utero and from birth. So when we're talking about airway, those structures are forming very early. And I had the wonderful privilege of editing for Dr. Guilleminault of Stanford before he passed. And so his last two articles I helped to edit, and it was just so much fun. He was a great friend. Whenever I had a question, I could ask him. I was so very lucky. So today you're just getting a snapshot that will hopefully guide you in assessing and treating babies and young children. Okay, so our goals are to discuss early oral development starting in utero, which starts very early. We're going to describe the full-term newborn structures, and we are going to look at the importance of appropriate mouth development. So this is on the home page of our website, agesandstages.net. We have the copyright on Ages A&D Stages for many years. And so don't confuse us with the test. For babies and toddlers, and this is Cannon, my youngest grandchild at 6.5 months, he's showing you part of what I'm wanting to tell you here. We need good body and movement development. We need good feeding, and we need good mouth play in order to have good mouth and airway development. They go hand in hand. And I'm preaching to the choir. You guys already know this, and you're helping to get the information out there. I encourage any of you who want to teach. Any of you who are teaching, please keep teaching. So then good mouth and airway development is needed for what? Good speech development and swallowing. So for children and adults, we also need good posture, body movement, passing a simple oral mechanism exam. Dr. Guilleminault, in his final article, states, and I think I may have put that statement in here somewhere, states that by 3 years old, a child should be able to pass a simple oral mechanism exam. You know what I mean? And we know we're not seeing that. We need appropriate eating and drinking. We have many children who are off track and many adults who are off track. So I had, again, the luxury. I've had such a blessed career, honestly. But when I got to teach for the Breathe Institute, we were looking at patients who were adults, and they were typical adults like you and me, and yet they had oral facial myofunctional problems. And when we assessed eating and drinking, they weren't eating and drinking properly. And then this helps us get ready to participate in sophisticated oral-facial myofunctional treatment and motor speech treatment. And oral-facial myofunctional treatment is pretty sophisticated. I think a lot of people try to start, like I was just talking to someone I was mentoring the other day, and he has a very involved patient with a very high narrow palate. And he was talking about suctioning. But there's a lot that has to happen before suctioning. And of course, I had my palate spread by Dr. Brian Hockel just a couple of years ago because I had traditional orthodontic work done when I was 30. I've had my premolars removed and they're back. Yay. And my palate is good and my airway is good except for whatever's going on. There's a lot of pollen here right now. So you'll also see this on our homepage. And so all children and adults, I think you would agree, need the best possible body, airway, and mouth structure and function. And it's accomplished by creating awareness via consumer-friendly, literature-based information. We have a lot of literature in our new course that's coming up. And it's completely literature based, thankfully, because guess what? We now have the literature. For so many years, we didn't have the literature, but we do. And it's coming from all over the world. And we need to provide families and professionals with an online and community education. And so, I just worked Wednesday 2 days ago with a therapist and parents of a baby of a 5-month-old in Mexico City. And so our community is worldwide and we need to educate so they can move forward with their processes if they don't know some of the things. I mean, this is my 46th year, and that means after being out of school. And then we need to prevent and correct body, airway, mouth structure, and function problems. You guys are all about that. And that will help us have generations of children and adults with these skills. So let's help to create this shift. And again, I don't have to really say that to you because you are already doing this. And I'm so excited about all the people that are doing this work. So let's see part of what I learned from Dr. Guimeno and others. So when we talk about the embryonic period, this is very early in utero. Around week 4, we see the face and oral cavity beginning to appear. And you know this. I mean, you've seen some of these sonograms. Many of you probably have children. You probably saw your own sonograms of this. And then about weeks 4 to 5, so we're still in the first trimester, the mandible, which, we see a lot of trouble with mandible growth and maxillary growth too. So the mandible, the lower lip, and the chin are formed and they start coming together. 5 to 6 weeks, we're seeing our lip closure. And so coming together this way, right? And so 6-week nasal and oral cavities become distinct. Look how early this is. It's in the first 12 weeks. Around the 7th week, we have our upper lip and our primary front palate formed. And these are places where we could have cleft lip and palate if they aren't formed and they don't come together properly. And then around the 7th to 8th week, our tongue muscles really begin to evolve. And the tongue lowers into the mouth and into the oral cavity, which is the mouth, as you know. And so this process seems particularly important for mandibular growth. Okay, and inside that oral cavity, we have sensory receptors. And a lot of people haven't really thought too much about sensory, but I'm going to show you some early people who did think about sensory. And now Ray Kent, Dr. Raymond D. Kent, he's one of my mentors. He's written a great article with his colleagues about sensory, and you can find that. Just look up Raymond D. Kent on your Google Scholar, and you'll see all of his articles with other people. All right, so Um, so the inside of the oral cavity has those sensory receptors, which I started to mention, and it's touch, pressure, temperature, and pain. And touch and pressure, very, very important for everything we're doing. Now, the tethered oral tissues, you probably know more about than I do, although I see a lot of them. And I asked Suzanne Morris, I'm going to show you a picture of her later. She's my primary mentor since the 1980s. And I asked Suzanne Morris, I asked a few others, Kathy Jenna, who's one of the best lactation people I know, why we might be seeing this, and also a pediatric um, or a pediatrician, actually. His name is Pejman. He's in LA. And I asked them why we are seeing these tissues not being resorbed. So they're there, but they are there for a reason. The reason they're there is to pull that structure and keep that structure together, or we might have a whole lot more clefting. Now, back to the tethered oral tissues just for a second. When I asked Suzanne and others about why we're seeing them retained, I mean, um, I am consulting right now. I'm just getting back to work after having a 3-year cancer treatment thing, but that's okay. I mean, I'm doing well. I'm cancer free. Yay. But the thing is, I asked them, why are we seeing all these uh, tethered oral tissues that we never saw before? We saw a little stringy tongue tie, maybe. We saw an upper lip tie. We weren't seeing buccal ties, and now we're seeing them all. So I was just consulting on a child the other day, and he had all of them. He had them released by a very good dentist who did a good job. So back to the fetal period and away from tethered oral tissues for a moment. 6 to 10 weeks. This is where your palatine shelves are really forming, okay? And that makes the floor your nasal cavity. So even though I have a little bit of a voice this morning, it's because the pollen is really high here in Las Vegas right now. So I still get a little bit of that, but I can breathe through my nose. I don't snore. I no longer need my CPAP. And so here is when that is happening in the fetal period, 6 to 12 weeks. This is when we can have cleft lip and palate occur. And so many of us, maybe all of us, have treated those children before. And then around 9 weeks, the facial structure becomes more is cartilaginous, which we know will then become bone eventually. And then 10 to 12 weeks, the soft palate tissue fuses, so you don't get a bifid uvula. And then week 12, the bone begins replacing the cartilage. Okay, and 12 to 20 weeks, we're seeing sucking, swallowing, and overall oral functioning organizing, and our taste buds maturing. So, 16 weeks, a lot is starting to happen there. There's the specific timing of sucking and swallowing developing along with the esophageal reflex. So I saw the child I just consulted on the other day. His esophageal reflex isn't working very well. So he needs somebody to work, a GI doctor, and to work on that because you can't get food, even if you have a good swallow here, you can't get food to your stomach unless you have that wave-like motion, the peristalsis, going down the esophagus. And when you swallow, like, I'm swallowing while I'm talking to you. When you swallow about, sorry, oral facial myofunctional therapist, let me do that again. No lip movement. I know that's what you want. But anyway, when you swallow about every 30 seconds, UC Davis did a study on this years ago, and the esophagus will move about every 30 seconds if you don't swallow like where I'm doing in order to keep my esophagus moving, or when we're eating food. If you're not swallowing every 30 seconds, the peristalsis in the esophagus uh, rests, so it doesn't have to work all the time. So I'm not saying we always have to swallow every 30 seconds, but just know if you're swallowing every 30 seconds, your esophagus should be moving everything, whether it's saliva or whether it's food, to the lower esophageal sphincter. Now, the the fetus at this time, around 16 weeks, starts to swallow about 7 ml of amniotic fluid a day. And then the fetus sucks and swallows increasing amounts of amniotic fluid until birth, and look how much. So the child I was consulting on the other day was only taking 12 ml. So, we have a lot of work to do. And then approximately 50% of our jaw and tongue growth occurs before birth. And of course, they are the gateway to the mouth and airway. And I have a good friend, Dave Page, who's a dentist in Maryland, who wrote the book, Your Jaw is Your Life. And so he started looking at this long ago. It was around 2000 when we met, 2001. When we met, he started carrying my textbook because he was looking at this back then. All right, so now let's talk about oral reflexes. We'll go over them, and but here's when they're happening. They're happening in utero. So your gag response appears 26 to 27 weeks. Your reflex is suckling and volitional sucking, which are different. Suckling is just like 2 per second. Sucking is 1 per second. That appears 27 to 28 weeks. Around 28 weeks, we start seeing that rooting response, the phasic bite, which is going to turn into the chew. And so that's straight up and down. And the transverse tongue, where the tongue moves over toward the stimulus. These are appearing at 28 weeks. 38 to 40 weeks, we see what's called an anterior tongue response. It used to just be called a tongue response, and it was confused with a tongue thrust. And so we call it now the anterior tongue reflex, because what it is, it's when the front of the tongue is stimulated, it moves forward, and this allows the baby to move the tongue forward over the lower gum area and cup to grasp the breast for breastfeeding. Okay? And then of course, the cough we see at birth, we wouldn't see that before. And then 17 to 20 weeks in utero, we're seeing hand and face movement. And I have a free course that I'm happy to give you. All you have to do is email me. You'll see my email at the end, and I'll give you a free course that has all of these, not the in utero ones, although I do have one in utero, that shows the child bringing the hand to the mouth, bringing the foot to the mouth. So our hand, mouth, and foot kind of connections are starting in utero in that very nice aquatic environment in mom. And so by 34 to 35 weeks, we see the coordination of this. Here's my mentor, Suzanne. I started studying with her in about 1983. And this is something Betsy True, an artist that drew this for her. She drew this for the pre-feeding skills book and some other things Suzanne was doing. Suzanne's very generous in giving us permission to use this You just have to email her and ask her to use it and get permission. But we're in the next slide, we're going to talk about what you're seeing here. You see that the palate is nice and flat. You see the tongue is filling the mouth and it's against the palate. You see the soft palate epiglottis actually touching. You see the larynx is high. These are all things that are protecting the baby for swallowing at birth. And so that's why a lot of people, even if babies are struggling with feeding, if the structures are in place, there's one thing not shown here I'll tell you about. But if these structures are in place, babies are, especially if they're typically developing, naturally protected for swallowing. The one structure I didn't tell you about was down here. It's called the sucking pads in the cheeks. Sucking pads are fat pads in the cheeks that are developed toward the end of pregnancy. So if a baby is not full term, so say um, they they were like a scheduled delivery, excuse me, we don't know if they're a full 40 weeks, they might not have sucking pads. Also, we're seeing a lot of babies born at 40 weeks who don't have good sucking pads. And so again, I asked my colleagues, Suzanne, um, Kathy, and Dr. Gimeno, why, and Petchman, I think you say his last name, Ketteray. But anyway, who's the pediatrician, I asked them, like, why aren't we seeing these sucking pads? And they said, well, are you noticing that the babies that are coming to you full term, they're on the low side of normal muscle tone? Well, if they're on the low side of normal muscle tone, then they often have cheeks that go like that rather than these fat pads, which are supposed to keep the cheeks against the gums. And that's where we're having a lot of our breastfeeding and bottle feeding issues. So you saw this, the mouth and throat structures are close together. The top and bottom jaws have a flat appearance. The palate, their babies should be born with a wide U shape. There are some dimensions from Dave Page there. Uh, the hard and soft palates create, as you know, the floor of the nasal areas for breathing. Babies nose breathe because they otherwise, if they didn't nose breathe, they wouldn't be able to suck and breathe and coordinate that. Right at birth, we also see something called nitric oxide that is being found in babies as early as 1 month, I mean, not 1 month, 1 hour after birth. And so, what does nitric oxide do? You know better than me. If we're not nose breathing, then we're we're not getting air to the bottom of the lungs. Nitric oxide assists with that process. Why do we need air at the bottom of the lungs? That's where our blood absorbs our oxygen. Wow. So mouth breathing is usually not going to do that. When I move somebody like onto a myomunchie, um, and I'll check them. I use my pulse oximeter. I check to see what their oxygen is before, and then I have a dentist who fits my myomunchies. And so once we have the myomunchie in and they really need to nose breathe, I check their oxygen again. Now, I found something very strange that surprised me. One of the things I found was that my children's oxygen levels often went up, improved, when their mouth was closed and they were totally nose breathing. The only thing I can think can explain that is the fact the nitric oxide is doing what it's supposed to do. Okay, now we are seeing this all the time, this retruded lower jaw. Now, my very good friend, Leach Pasquet, who passed away, um, when she did her talks, and she was wonderful. And so when she talked about the fact, and also there's a dentist in Illinois um, named, I think his last name is, oh, it's Kevin Boyd. And so you have to forgive my 70-year-old brain, but but I still do pretty good. So Kevin Boyd, they talk about epigenetics. And when you look at our previous hunting and gathering societies, or some that are still there, they don't, those babies, they say, were not born with this retruded lower jaw. So we have to attend to that retruded lower jaw. And how do we build and form bone? Through chewing at the molar areas, even if you don't have molars. Okay. Um, so then the nasal turbinates, I learned this from Dr. Yimano. They're very large in the newborn, but they decrease in size very quickly. They're large in the newborn because the baby's not breathing through the nose in utero, right? So right after birth, they decrease in size if there's no inflammation present, okay? And then you know about sucking pads, eustachian tubes. They go from the back of the nasopharynx into the middle ear space, and if you have, they have tone in them. If you have low tone, that's some reason that we get collapsed eustachian tubes in some people, which will cause retracted eardrums, and that causes a hearing loss even without an ear infection. And that's happening in the middle ear. So there you go. So here are our newborn facial characteristics. This is Grayson, one of my grandsons. And so you can see his eyes are areas nice and wide at birth. He has a nice nose angle. He has a straight lip line, but he has a retruded lower jaw. And because we only have an hour, and I want you to have this, so I created this so that Renata can make this available to you. Uh, you know, I don't mind you having this um, presentation uh, in a PDF form. So the center corners of the eyes are in line with the widest part of the nose. Okay. And then, like I said, a good nose angle. And so here are some of the other things that we talked about previously about the size. And the jaw grows forward very well in the first 6 months if the child is getting the proper stimulation. Now on our website, and here is the site address, we have all of this in English, Spanish, and Italian. So they're all literature-based checklists from birth to 12 months. And looking at all of these things in the areas of body and movement, these changes in different positioning, all the way up to crawling, standing, cruising, and walking. And it's all literature based, okay? And then mouth and feeding changes over time. And so here are some of the things that we have already mentioned. And I'll talk again about tooth eruption. The Moro response, this is what you see with babies lying on the back when they're startled. It's called the startle response. And you know how you feel when you're startled. So they are, let me take this off my screen. There we go. They, good grief. Okay. Stop sending me messages.
It's okay. The okay on the bottom probably worked. There
Okay,
you go.
I
Yay.
moved it down.
It's okay. This has been great, by the way. I'm so good.
So the Moro response, it's all these three are observed at birth, and I even created a little funny video for the Breathe Institute where I got down on my yoga mat and showed people all what these responses are. But that releases adrenaline. This initiate is for initiation of labor and the baby taking a deep breath and crying at birth. And then it's integrated by the brain about 3 to 6 months. The tonic labyrinthine reflex has to do with flexion and extension in the body. And this is how we develop our muscle tone. So I'm a low tone person on the low side of normal. I don't have low tone like somebody with, say, Down syndrome or another syndrome, but this low muscle tone runs in my family. And so um, just because you have muscle tone on the low side of normal doesn't mean you can't stay on track with development. And so this reflex helps with our awareness of the upper and lower body, and it probably helps with the birthing process. And so again, flexion is integrated by the brain at about 4 months, whereas extension up to 3.5 years, because what are we doing? We're crawling, we're standing, we're cruising, we're walking. The asymmetric tonic neck response helps the baby move down the birth canal. And it frees the nose and mouth for breathing, like if the baby is on the belly. So we hear a lot about tummy time. I'll talk about side lying time, because if you don't get side lying time, you're not going to get good coordinated rolling. But we're playing with our babies in tummy time. We're playing with our babies on each side. And so it really does help get, if the baby is on the stomach, it helps the baby get the head moved to the side. Later, it helps with eye-hand coordination, reaching for objects. And so it's integrated about 4 to 6 months of age, after birth. Now, the symmetric tonic neck response. This helps the baby with crawling. They push up on their hands and knees to creep and crawl. It also helps with focusing vision. So we know all of these systems are connected, right? And so it's observed at 6 to 9 months of age, and we see it integrated by the brain around 12 months. And what's that baby going to do? Start to pull up and start to cruise. Okay. Now, these are the mouth responses. And so rooting leads to sucking. And of course, you are allowed to have this, so you can go back and read more about it, because I don't want to. We started about 6 minutes after. So I want to take the hour and give you some time for questions. But rooting leads to sucking. Suckling is a precursor, which is suckling 2 per second, is a precursor to sucking. The anterior tongue response assists with breastfeeding. We talked about that. Nutritive sucking, 1 per second. The phasic bite works the jaw muscles. The transverse tongue helps with lateral tongue movement. The gag is on, in the newborn, about halfway back the tongue. I asked Kathy Jenna, Dr. Kimino, and Suzanne Marth about this, because there are some resources that'll say the gag is on the front of the tongue. That might happen if you have a child with some kind of neurological problem, but the typically born child, the reflex is right here, 50%. And then over time, through hand-mouth experiences, feeding experiences, experiences with toys like the Beckman Tri-Chew, or this is a new one, the Itsy Rings by Talk Tools. By 3 months of age, where I introduce these to my babies so they can put their hands on them and bite, 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 all the way back to what will be the molars. And what helps teeth come in? Biting. So there are 3 hand-mouth reflexes, because hands and mouths work together. The palmomental stimulates these muscles here, the mentali. What do? Evert the lower lip. What's that for? Latch. When we use it in our production too, some people, in speech. Babkins, the baby, you put your hand in the baby's palm, the baby's mouth opens, the eyes close, the head moves forward for feeding, and the grasp tightens. It actually, in fact, I just found some great research on the grasp and how it is connected to other things. And that'll be in our new course. But here's where control develops, and here's where integration develops for these. Now, oral sensation. We're just starting to look at this more. And you can see as far back, Bosma, he was one of our fathers of this work. James Bosma, also from Maryland. And so through the National Institutes of Health, he published this. So as far back as 1969 and before, we were looking at the role of the sensory systems in the body and the role of these important areas or structures. So the mandible, the hyoid bone, my goodness, I have a whole slide on the hyoid bone and how it's connected to so many things. And then the tongue, and you know, the oral surfaces he discusses. I'm not going to read it to you, you can read it. And then back here, again, the University of Maryland Dental School in 1995. We have a lot more recent information, you know, very recent, on what's happening in terms of sensory in the mouth, and Ray Kent is part of that. So again, it talks about these mechanicoreceptors that receive these sensations, and then oral kinesthesia, your awareness in your muscles and joints, your oral stereognosis. Dr. Guilleminault's final article on apraxia was about oral stereognosis, the ability to discriminate form within the mouth. Now, all right, oral awareness. Generalized mouthing starts in utero. So if you ask me for that course, that free course, I give it to you. You have it 6 months. If you want it longer, you just say, Diane, extend it. I do it. It's on my website, but I have to activate it for you. So, generalized mouthing begins in utero with the baby bringing the hand to the mouth, sometimes even putting the fingers in the mouth, bringing the foot to the mouth, sometimes even putting the toe in the mouth, okay? And this generalized mouthing happens mostly at the front of the mouth and occurs till about 4 or 5 months of age. And so here's where the baby's expanding exploring all these things, including appropriate mouth items where the parent can hold this with the child and the child can explore it as different textures. I use all of them, but the large one with my 3-month and older children. Discriminative mouthing, this is where oral stereognosis fits. Discriminative mouthing begins about 5 to 6 months of age, and the child's exploring the hands and the fingers and moving the hands and fingers all around inside the mouth. And what are we introducing? We're introducing complementary foods. And there are a couple of tools. This one is Talk Tools, and this one is Mary Schiavone, a good friend of mine, Chewy Tubes, where at 6 months, of course, we're doing this all under supervision. I mean, we're not just handing to the kid and expecting the kid to do it. But eventually a child will learn to do it on their own. What's really nice about this is they can explore the handle of this one. And on this one, they can explore this little circle. So also at that time, there are spoons like this that the child can, or the parent can dip into the food. And then these are 2 new ones from Talk Tools, which the baby can hold with the parent. And you see it looks like a spoon. and so they can take food off of it. It's also safe to bite on. And then this is a dipper where the baby and the parent can hold it together. And I always recommend parents and babies work together. Babies are born with mirror neurons. We have that research in the new course. And so they do what they see. And we really aren't meant to eat alone. So whenever I work with families, I have them, even have if I have a graduate student and I'm treating, everybody has to eat and do the kinds of things they have to do for good feeding. And we won't go into feeding because that's not our topic, but if you've taken my Talk Tools course, or you've taken my other Northern course, or any other of my feeding courses, you'll see what all that's about. All right, so this is interesting. So this study, I believe, is from Brazil. I have them from all over the world, but this one was showing that the oral habit of putting appropriate objects in the mouth positively influenced and contributed to adequate oral skills when using a cup later on. And so, and let's see here. And all this is needed for eating, drinking, and oral hygiene. How important is oral hygiene? And how many of the people do we treat who one of the first things I ask is, how are they doing with toothbrushing? And so I always work on toothbrushing to bring about not just better oral hygiene, but also we move that brush all around the mouth. We brush the tongue to get that awareness going in the mouth. And then here is a baby. You'll see this in a picture in a few minutes. Brush that can be used all, it's nice and soft. You can get it in any drugstore, can be used all over the mouth. Right. Now this is Cannon. This is my youngest grandchild who you saw earlier, like up and crawling at 6.5 months. But I'm doing oral massage with him. So I work usually from the arms up toward the face, around the lips, then in the mouth. And so what you see is Cannon is nicely bringing his hand to his mouth as I'm doing some on-off presses on his arms. I don't dive right into somebody's mouth because so many of the clients I work with have already become what Suzanne Morris would call orally defended, or you may hear oral defensiveness. And so he's mouthing his hand. I'm very happy with that. Then he's holding his tri-chew, which he became safe with and could eventually take into his crib with him because he was safe instead of a pacifier. And so he's holding his tri-chew and looking at it and smiling as I'm massaging his face. And then when I get to his lips, you can see the concentration in his eyes. He's really concentrating on what I'm doing at his lips. Then when I go into his mouth, I go into the cheek. And so Cannon had and this will be in our course, so it's not a secret. Cannon had some problems at birth, some medical issues at birth, but we've kept him on track, and he's in regular school. But anyway, he would have been one of the kids who might have been nonverbal if we didn't know who to get. I mean, it wasn't just my daughter and me and our families. We had a team. We had OT. We had early intervention. We had a couple of speech therapists. So we had a team to work with him when he started having trouble with speech later on. However, what we're doing here is I'm going inside his cheek and I'm doing some massage inside the cheek, and I always do it the other one too. This is a tongue cupping activity where we work from the front of the tongue and we work our way back. If we see the gag response, we move forward and we move up toward it again. We don't want to gag the child if we don't need to, although you'll see me gag somebody in one of the videos in the free course. But of course, I'm not going to keep on gagging her. I just found that that's where her gag was, and then I'm going to work getting the tongue cupping and grooving, which we need for food collection and we also need for speech. And so we work very early. You'll see two babies in the free course, Kate and Shani. And so I'm working on that with Canon here. And again, here is the phasic bite response. I use the fleshy part of my finger with the rest of my finger outside, and I stimulate the phasic bite response at the back molar area. Now, in children with Down syndrome, sometimes you can't get a phasic bite, and he doesn't have Down syndrome. He was actually typically born, it's just he had some medical complications right after birth. But the thing is, if you can't stimulate your phasic bite response that way, you can stimulate your phasic bite response by turning your finger over and stimulating the mandible, because chewing and chewing-like activities builds and forms bone. Okay, so these are the early structural development items that you're going to see in the first 3 years. And you'll see there's a number of them. I'm not going to read them to you, but it gives you an idea of what you should be seeing in that first 3 years. Now, you guys know if you're in the dental area, in particular, the primary teeth should be emerging during this time. They need to be emerging on time, in proper sequence, on time, fully formed, and with good occlusion between 30 months. And we know that. I just looked it up on the ADA, the American Dental Association site, to be sure that these are still in place, the ideas of the timing. But in children with Down syndrome, we were seeing they weren't coming in a proper sequence. They weren't coming in on time. If you've worked with children with Down syndrome or other problems, other syndromes, they don't necessarily come in fully formed. They may not have the enamel in them, and they're not getting good occlusion. And a lot of those kids, because of their tone, they're mouth breathers, which I have worked with. If you take the Talk Tools course, not that I'm promoting it, I'm just saying the Talk Tools course is in English and Spanish. And there you will see videos of me working with children with Down syndrome if that's an area that you need. So I'm not trying to sell my courses, believe me. I'm just happy with what I believe is that people should do and study what they need to study at the time they need to study it, and not just because Diane Bahr said this. All right, so this is Anthony. He was the model for our 2010 book. And here you'll see the facial characteristics, the straight lip line. You'll see that by the age of 6 or so, or even earlier, during that first year, there's a lot of jaw growth if we're getting that stimulation at that back molar area with the phasic bite. So you'll see a nice angle here. You'll see that he has a little tipped up nose, but it's not more than this. I'll show you the measurements next. And I use a goniometer to measure these angles. So these are the facial characteristics that you should see, and they're from Char Beauchart, who is a longtime orofacial myofunctional therapist and another one of my mentors and a reader for our new program. And so here you go with it where you saw previously. We draw the lines and we see that we have approximately 1, 2, 3, 4, 5 eye width across the face. That's what we really should keep. We see that we have at the hairline, at the eyebrows, base of the nose, and at the chin, we have equal thirds. That's how faces should develop. And the nose angle should be 90 to 110 degrees. Now, the importance of mouth development. It's extremely important for health and well-being. I know you know this. It's for nutrition. It's where babies, when they do all of that hand-mouth work, they're gathering information about their world. And it's where they ultimately learn to speak. And we have an awful lot of late speakers and late talkers. So I have not been directly treating during the 3 years of the cancer treatment, but I still have been doing consultation, writing, that kind of thing. And I can't wait to get back to treatment. But please do not refer people to me yet. I'm looking to work in a dental office. This is my office, but I'm looking to work in a dental office maybe one day a week where they see everyone from birth up. Um, and I feel like that would be a good place for me to be and see the kids that they're where they're getting the releases and all those things. Birth to age 2 years, critical learning period. So this is where we're developing the majority of our eating and drinking skills we're going to use throughout life. And our mouth structure is, coming into order what as it should be, and our mouth function is what it should be by then. And we have good guidelines on that. So here is my information. This is our website. And, just email me. It's right down there. Just say if you want that free e-course, and I'll tell you how we activate it. And then you know about the books, you know about the developmental checklists that are on our site for free. So you just go to developmental checklists and look there. We also have lots of blogs and Q&As from wonderful people. Um, so, you can look at those blogs and Q&As, and we haven't put a lot of them up recently, but they're still not out of date. You know what I mean? It's like how I showed you the research started way back. And they're still not out of date. And there's my phone number. If you really need me, you can call me. Thank you, Renata.
Wow, this was unbelievable. Thank you so, so much. I am so glad that you're feeling better and
Thank
you
you.
accepted to come speak to us. Oh my Lord. I have so many questions.
Okay.
You mentioning they're swallowing in utero. Do you think that hiccuping means that their swallowing is already dysfunctional in the womb?
I
Oh,
don't have
do
it.
you mind? Do you mind stop sharing the screen so we can do a cut without?
Oh, sure, yeah.
Awesome. I'll
So
repeat the question so we
yeah,
can.
so give me, okay. So
Hold on.
let's see. You have references.
Thank
Um,
you.
I can't see the screen share
Should be on the bottom
thing. Should be on the bottom
if you
here.
run your mouse over, you see the bar. It's just a bar.
I'm not getting it here.
Let me see if I can try to share my screen.
Okay, I see share, and I don't
Stop
see
share.
stop share.
Okay, so let's see if I try to share mine.
But you can probably stop my share, right?
No,
No?
I tried. Let's see.
Okay.
Change the speaking language. I don't know. Remove spotlight for everyone. Sorry, guys. Hold on. Um,
I took it down.
share settings. No, it's opening up. If I try to screen share,
Mm-hmm. Okay, let's not worry about
yeah,
it. Let's just
no, but
talk.
it lets everybody. I need to be turned off so we can see ourselves
Okay.
big.
Okay. Well, turn I cut out my presentation. I just X'd it out.
Yeah, I can. We can still see your screen though.
Hmm. That's it.
Click
The
if
one
you
that
click on Zoom, you might be able to find it if you have Zoom on your bar.
No. Okay.
Any
There we
second one?
go.
Oh, there you go. Thank you. Awesome. Okay, perfect.
Yay!
Let me do this. Okay, great. All right, let me ask the question again. Does
Sure.
hiccuping means that their swallowing is already dysfunctional in the womb?
I have no idea. And that's one of the things I'm not afraid to say because hiccuping is kind of common,
Okay.
and so Kathy Jenna would probably be the best person um,
Okay.
to ask about that.
Because usually in
Um,
a normal day to day, we're not hiccuping. We usually
no,
hiccup whenever we swallow wrong.
right. And that's true. So it could be, it's a great question.
I would love to
And
know.
it could be, it's something to keep in your mind. What the other thing I believe is there's a lot of things like when I said to Suzanne about all the retaining all these ties, she said, well, if you didn't retain the ties and we have underlying low muscle tone, the structure might not stay together.
Mm,
Something to think about. So now we can correct that once they're born and we find them.
wow.
So Pechman, the pediatrician, believes it's metabolic. Um, and he would be another good one to ask.
Yeah, send me the names. I'll give him a call.
Okay.
How does prenatal development influence the readiness of an infant for feeding and speech?
Well, I think that's why I did this for you.
Mhm,
Because if we do not have uh, structure and function that stays on track, beginning in utero, how are we going to get good feeding and speech? Now, if the structure has not stayed on track, that's why there's people like me,
mhm,
feeding and motor speech therapists, right? Because then we work with things after birth, like yang, 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 3 sets of 25. I did this the whole time I was getting my palatal expansion. I still do it to keep
amazing.
to keep my mouth in shape. But if we don't after birth, we can kind of make up for things that maybe they didn't keep up with. And with cleft palate, I treat cleft palate. There's a lot we can do. The biggest problem with cleft palate is the scar tissue. And it's
Mhm.
why I went to massage school and became an NCTMB at one
Wow.
point because I needed to know how to work with scar tissue.
Oh, wow. What can parents do at home to assess oral motor skills in infants during the first year? What are some,
Yeah.
do you mind repeating? I know you've already mentioned, but some simple things that parents can recognize.
What I recommend is that they go to I don't want them overwhelmed,
Mhm,
but I recommend they go to our website. The new course I'm going to be giving it in English, um, maybe in the future in the other languages, but I have what should be happening in the body,
mm,
what should be happening in the mouth, and all of that is listed there. And parents, if you're listening, do not get overwhelmed. You
mhm,
go to the one for your child's age. You pay attention to the good things they're doing. Because
mhm,
chances are, and all children develop at their own rate. So you pay attention to the good things your child is doing, and the same with the therapists and the other professionals. And you don't get upset about the things they're not doing. We facilitate the things that they're not
mhm,
doing. So that's why that birth to 1 year is on there, because we have so many kids falling off track during that time as well. I'm not against bottle feeding. I in my course and in my 2018 book, I have a side by side bottle feeding and breastfeeding. So I'm not against bottle feeding,
mhm,
but breastfeeding, of course, is the atomically the best thing for the mouth, but that's not always what somebody can do. I mean, my daughter did a combination of breast and bottle feeding with their children.
Mhm.
And so you just have to know what you're watching for.
Right. And it's 2026. Our lives are so different. Unfortunately, not everybody is able to nurse these children,
Hmm.
the right amount of time and only nursing. We all know that.
And
Uh,
how do you go out for an evening? So, I mean, my daughter and son-in-law, when our firstborn grandchild was there, my husband and I, we stayed with her while they went out for a nice dinner.
that's so nice. I never did that. I didn't. I was like hermit crab when I had my kids. I didn't get out of the house for a year at least, I think,
Well,
maybe
but
even longer.
I
But
was
it's
the
not,
same.
it's not healthy.
I was the same because I was a 1970s mom. So my
Uh,
daughter was born in 1977 and I breastfed and we didn't go out and do much. And
mhm.
I stayed at home with her for 3 years. Not breastfeeding. I mean, we introduced foods
Yeah.
appropriately and all, but and mouthing appropriately and all. But I had the luxury of staying home a year
Oh,
and breastfeeding
amazing.
her. And with breastfeeding, you get very nice side lying if you're using a
Mhm.
cradle or a cross cradle hold.
Amazing. As a professional who practices myofunctional therapy, what are some unique considerations for premature infants regarding oral maturation? And I ask that because I'm getting the children at 4 years old, 5 years old, but even adults, this is a question that we usually ask.
Yes.
How was birth history? How is that related now to an older patient?
Oh, of course. Well, it's so funny you asked because that's the child I just saw on Wednesday, and has a corrected age. So we have to go with the corrected age of the child with development in the first year if they're born prematurely. My population started out at the Maryland School for the Blind with a lot of preemies and a lot of kids with cerebral palsy.
Mm,
And so the thing is that you do need to ask the question. I worked for the public school system for a short period of time, and nowhere in those records at that school system was the fact that this child was born prematurely.
mm,
And so that is something we have to always ask. And it doesn't mean we're really good with preemies now. We have that's in the free e-course. We're really good with preemies now in that we can keep them on track if we
mhm,
know what to do. It's simple stuff.
mhm.
I'm helping this dad right now here in Las Vegas, just consulting because I'm not treating actively yet. And 'cause I just had surgery like 2 weeks ago.
Oh my
But
goodness.
but but I'm helping this dad, and he had a great therapist who got him started, but he couldn't get it going at home. So I was coaching him in how to do this at home with his child, and he's making very quick progress because you know what? This work is not hard. It's very so in my like Talk Tools course and other courses, I always taught about what the tools were for. And that course came out of my course at Loyola University that I taught for 11 years.
Wow.
But that's because people didn't know what the tools were for.
Mhm.
My new course is all about structure and function and using only the tools that you need.
All
I
right.
didn't show you a whole bunch of tools here. I showed you the few that might work for early development.
Do premature babies have more retained reflexes? And even as adults, do they still have to go back and get those reflexes integrated?
Oh, yeah. Even full-term babies have retained
Huh?
reflex. So you see, they don't integrate in the brain
Mm-hmm.
so these reflexes are developing in utero, and well, the body reflexes are used to help with birthing.
Mm-hmm.
Um, but the
So C
mouth re
C-section babies are increased and preemies are increased.
well, I can't tell you.
Okay.
C-section babies do not get the squeezing and all that pressure that happens coming through the birth canal. I was lucky. I was told I was getting a C-section. My daughter came through the birth canal. Um, but, not everybody is that
I
lucky.
had two scheduled C-sections.
Yeah, yeah. So, like infant massage, the reason I'm an infant massage instructor is so I can teach parents to massage their babies, especially those that didn't get all that good pressure when they were being born.
I love that you said this because I've been saying for years that um, it makes me want to have another baby just so I can massage him every day because I had no idea how
Absolutely.
important it is to just massage their little bodies and get those
Yeah.
muscles, oxygenation and get them moving better. Like, I don't
And
want to
there
wait
are
for baby.
there are a lot of us out there. There's Nina Johansson, who I've mentored as well. She has a different infant massage certification. I'm through the original organization with Vima McClure, but I got my certification in 1994, which shows
Mhm.
you how long and I graduated from massage school in addition to working full time as
Wow.
a speech therapist in 1994 because
Wow.
what you're talking about is so, so important.
I have a question that we hear a lot in our field. The myofunctional therapy is not for children under 3 or 4 years old,
Okay.
that
Hmm.
it's considered oral motor therapy and that only speech pathologists, occupational
Okay.
therapists should practice. You are very familiar with how things are done in Brazil. I know our son is a good friend of ours.
Yeah.
Every course that I have taken in Brazil, they don't separate that. Everything
Right.
is
Right.
myofunctional therapy. Can you give us a little bit of a light into that?
Technically, it is. Technically, it is. Now, because in the United States, we started with Daniel Garliner, oh, trying to think the gal that wrote Swallow Right, Roberta Pierce, who did a
Mhm.
lot of research. But they were, and a lot of the people working with oral facial myofunctional work, they were
Mhm.
working when children were getting things like braces or
Mhm.
needing things like braces. And so now we know that this is very early oral facial myofunctional work. But it's
Mhm.
so funny you asked this question. Just before we went on, I got a call from an insurance company.
Mm.
This insurance company does not, will not reimburse for oral facial myofunctional treatment,
Mhm.
period. It's right in their guidelines. Now, that's not why I said this. The truth is, here in the United States, I act as a feeding, motor speech, and mouth function specialist.
Mhm.
And when I have somebody who's ready for traditional, and that's where you're getting this definition change. Traditional oral facial myofunctional treatment, like Barbara Green, I put her in our course, and we have a good um, article from her on our well, couple on our website. But that's the problem here in the United States. The United States doesn't, even though technically it is, you know, we had this big controversy about any oral functional work.
Mhm.
And it lasted 20 years. Pam Marshall and I, we developed the Oral Motor Institute.
Wow.
And if you go on there, you'll see the monographs where we were studying because speech therapy in general wanted to move away from all of the feeding and mouth function stuff.
Mhm.
And now we have lots of research, which is why I have over 300 slides, and it's a
Wow.
10-hour course in the new course because it's all connected.
Mhm.
And Rosanna is one of the best
Mhm.
in terms of measurements. I mean, the measurements I showed you, they're basic and
Mhm.
they're easy to see. But Rosanna, my goodness, her measurements are very sophisticated. And actually, when you talk about traditional oral facial myofunctional work, that usually starts around age 6 um, here in the US.
Mhm.
And so all over the world, um, they're using the general term for all ages, I think,
Hmm.
except here in the US.
Except here, I just think it's because we
Mm-hmm.
don't have standardized training. There's like
Mm-hmm.
not like a university degree that tells you exactly what it is and how to
Right.
practice. So everybody's teaching something,
Right.
and it becomes a little confusing. So thank you for touching on that
Well,
subject.
but I'm so thankful to all the people teaching oral facial myology here
Mhm.
in the US. I mean, one of the ways we get, so the dentist, the pediatric dentist I plan to be working with, he took Mary Billings and Diana Davidson's
I took hers
course.
too. It was
Yeah,
wonderful.
yeah, yeah. He took Kathy Jenna's course, but he's a pediatric dentist. He can't be
Mhm.
expected to do that therapy with the babies where he's releasing those
Of
ties.
course.
He needs somebody to do that therapy and teach the, not that. What we're teaching are habit systems. So we have to support and coach the family so they can do the work every day. And it takes at least 2 to 3 weeks to develop a habit, and then sometimes more. I have the literature on that as well. So, you know, uh, I'm not against what's happening anywhere. I think we just have to understand what people mean when they
Hmm.
say what they're doing.
Yeah, we need some clear definitions. I agree.
We do. And Ashley's getting better.
Hmm.
Thanks to our colleagues who have worked with Asha to get, better information there.
All right. Well, thank you so much. I have more questions, but we're a little bit over time. I just wanted
Okay.
to be able to ask as many as I could. Thank you
Okay.
so much for this wonderful presentation. For everybody on Area Circle, as a member, I'm going to be adding everything that you sent to us right underneath
Okay.
this talk. It's going to be available
Right.
right away today
Good.
for our members and for everybody else. You guys are going to be seeing this
Yeah.
on May 7th. So thank you, Diane, so much
Right.
for hanging
And
out with
you
us.
know, email me, don't
Okay.
overwhelm me, because I get like 150 emails a day. But
Yes.
but really, I honor your requests.
Thank you.
So I'll be back in touch if you're in touch with me.
Thank
Have,
you.
have
Definitely, I will. And for everybody listening, our advanced myofunctional therapy course starts August 1st. I know we're so excited about it. It's the why behind the exercises. So it gives you
Yes.
the explanation. Why are you doing what you're doing? Why are you giving that prescription? Why are you telling them to hold something for 2 minutes? I bring all of the research from Brazil and the exercises that are no longer used over there because they've, did research and doesn't work anymore. We should be
Mm-hmm.
putting those behind us. But if you want to understand a little bit more about what you're doing, with that, you're going to get better results. First, you have to do a
Mm-hmm.
really good evaluation. The better your evaluation, the better your treatment plan, the better your results. So
Absolutely.
if you're ready for the next step, guys, go to areacircle.com and
Right.
click on Mayo Circle. Starts August 1st.
Right.
It's 16 weeks long. So super excited about when
I
they.
love that. I love that too because that's about the length of a university course.
Mhm,
When I taught with a colleague the feeding and swallowing course at Loyola
mhm,
for about 11 years, um, it's 14 weeks.
mhm.
Plus, we had freestanding clinics where our students could actually practice the work and
That's
we could
amazing.
work alongside them.
Oh,
So I think we're really coming along throughout the world with this. I mean, I think oral facial myology, in my opinion, is the hottest topic in the world right now when it comes to
I
what's
agree. I
going on in the
agree.
mouth.
Yes, we decided to do something longer because everybody gets so overwhelmed after they take their first course. It's so much information. They're like, okay, what do I do now?
Yeah.
The 4 days course, I think they're long gone. I don't think people do those anymore. So we have
And
two courses. Foundations is 12 weeks. Plus, we do 4 extra meetings, so 4 extra months of
right,
mentorship. So as soon as people start practicing, that's when they start having questions. So we
right.
decided to do 4 extra mentorship meetings after they're done with the course. And then,
Right.
but they still have a whole year. We have a WhatsApp group
Yes.
that's a study club, a whole year of help. So anytime they need
Yes.
anything, post about patients, you need that support, that community to
Absolutely.
help you, and your colleagues can also help you in that group. So it's really fun. And then the
Well,
other one is 16
yeah,
weeks.
And working with the Breathe Institute, that was an important piece of what we did. And so, as I said, variations on a theme bring. I mean, I may have said variations on a theme, but I may not have said what it does. But
Mhm.
variations on a theme, learning things in different ways and
Yes.
why you're doing it, that helps you integrate the information in your own brain. So I've
Yeah.
taken courses with just about everybody.
Yeah, same here. Same here. I've learned from so many people, and I always say that everybody holds a piece of the puzzle. Every
Definitely.
instructor that you take is going to teach in their own language, and some people might really connect with you. Some people might really connect with somebody else,
Right,
but everybody holds a piece of the puzzle. So we all know that
right.
one course is not enough. We're all taking several courses in this field.
Right. And as
So
I get, because I just turned 70 last month,
no way.
on the 24th of
Happy
February.
birthday.
Happy birthday.
Yes.
But and I've been doing this I've been in practice since 1980. And
Wow.
then of course I was in school doing this before that. But
Incredible.
you know, we really do need to respect that people do have pieces of the puzzle, and that's why
Yes.
I like the online courses. For me, because of my age, um, the one I have through Talk Tools, you can take your time and take it.
Yes.
You can go back on it. The one with Northern lets you keep their courses forever.
We do too.
So,
Forever access.
yeah,
Hmm.
yeah, it's a great idea because you might not be ready for a certain piece of
Yeah.
information, but if you've taken that course and you can go back to it, then you can review that section.
And we have students that go back years after they've taken the course, are like, oh, I needed to rewatch that one class again. And they hear something
Exactly.
different. They learn something different. So
Exactly.
as long as we
Exactly.
all support each other, I really think that our
Yeah.
facial myofunctional therapy is going to keep growing in a positive way in the United States and in the world.
Okay. Well, and the whole world. I
Yes,
mean, the Switzerland conference, I don't know if you went, but
I did.
I heard great things. And I couldn't fly for a long time
Hmm.
because of my condition. But
Hmm.
hey, I was so excited about that.
It was incredible. Next year, it's July, I think 7th or 9th, something like that, guys.
Mm-hmm.
Time conference. It was incredible. St. Gallen,
Right.
cutest little city. It was amazing. I cannot wait to see everybody again next year. But thank you
Yeah.
so, so
You're
much. I'll share
welcome.
everything with everybody. Guys, if you have any questions, please let
We,
us know.
and we
Um,
could talk forever, right?
I know. We gotta go. We love you
All
guys.
right.
Thank you so much.
Bye.
Have
Thank
a
you.
wonderful day. Bye
Okay,
bye.
you too. Bye.